in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey. This is Buck Joffrey, and today I've got back on my friend and colleague and urologist, Justin Houman. Justin is as I mentioned, a urologist who is a specialist in sexual health for men and women alike, and he is he works in Beverly Hills at a place called Tower Urology, and he's also an assistant professor at Cedars-Sinai. He knows pretty much everything there is on this topic, so it's great to have him. Justin, welcome back to the program.
Thanks, Buck. Thanks for having me. Good to be back.
Yeah, we had a really interesting conversation last time. I thought it was actually for me at least, it was one of the more interesting things because I feel like this topic of men's sexual health in particular, it's a sleeper, right? It's really like something that is grossly underappreciated. I think a lot of men suffer with these issues, and they're just not dealt with as probably as quickly and as efficiently as they should. But before we kind of get into some of the extended topics that I wanted to follow up on from last time, let's start with some basics. Is it true that testosterone levels in men in general have gone down significantly over the past several decades? And if it is, why do you think that's happened?
So I know this made the press recently over the last year because of declining testosterone rates.
Right.
I think I don't disagree with it, but I think there's two things going on. Number one, we're checking testosterone levels at a younger age and more commonly. So the frequency of testosterone testing is gone up. So as a result of that, you're going to catch more. You're going to diagnose low testosterone more as a result of it. Number one. Number two, I think our lifestyle, as we become more sedentary, has become more office jobs, desk jobs, spending more time indoors, not doing the things that are important to normalizing testosterone levels, getting outside, vitamin D levels, getting good sleep. I think with the constant blue lights everywhere, with phones and TVs, Netflix, everyone's, you're constantly being stimulated. Our sleep is getting disrupted as a result of it. Food, we're eating more and more processed foods just because of the ease and convenience of things. So, maintaining normal testosterone levels aren't difficult, but our current lifestyle it doesn't promote normal, healthy testosterone levels.
Yeah, that's actually interesting to me because I think about even growing up, back I was a kid in the 80s and 90s and stuff, and we lived a different life, man. I mean, we were running around playing out. There was, you had video games, but that was kind of what you did after a day of like heavy physical exercise all day long, right?
Yeah, exactly.
So
right.
I can totally see how from a lifestyle standpoint that would affect it. And we ate junk back then too, right? Arguably it may have been worse because we were doing like Twinkies and all that, and we didn't even know it was bad for us, but that's an interesting thing. So let's do this. You see people, you see men who, and we're going to focus on men today. You see a lot of people presenting with low testosterone. Now, granted, they probably go to their primary care physician first. It's usually the presentation. They're usually presenting their primary docs. When they do, what are the most common symptoms of just low T? I mean, obviously erectile dysfunction is something that you always hear about, but there's lots of symptoms here that might signal low T.
Yeah. So, I mean, the common symptoms of low T, like I'll give you the most common ones, but sexual side effects or sexual issues. So libido, erectile dysfunction, low libido, erectile dysfunction, fatigue is a big one. Another common one is guys, they'll be like, look, I exercise 30, 60 minutes, a couple times a week, and I'm not noticing any difference.
Mm-hmm.
Like I can't gain muscle. I can't lose fat. I'm sleeping poorly. I'm more irritable. My mood's off. And my partner says there's something off with me. Those are the more common ones. But I would say the two most common, fatigue and sexual issues.
Right. What are some of the less common, the sneaky ones?
Insomnia is one.
Okay. Interesting.
Yeah. When the sleeping is not what it used to be, like the waking up in the middle of the night. I'd say the other less common one probably is mood disturbances. So Yeah, like I said, a little bit more irritable. It's ironic because high testosterone levels would, like, if you have super high testosterone levels, it makes you quite irritable. But when you have low levels, significantly low levels, it can make you irritable as well.
Right, right. Let's talk about like what normal testosterone is. And I guess this is kind of where my head has been lately. Are there target numbers that you're looking for? And maybe you can kind of comment that within the context of these terms that we hear when we talk about total testosterone, sex hormone binding globulin, free testosterone, bioavailable testosterone, all these things, maybe just to kind of get an overall sort of lay of the land of what this terminology is and what people might be looking for.
Yeah. So we say normal testosterone levels are anywhere from 300 to 1,000, which is a very wide range. And it's quite unfair to measure testosterone that way, because it's like if a guy comes in with a testosterone of 310, there's going to be many doctors who are like, well, technically you don't have low testosterone, I'm not going to treat it.
Right.
So the objective value is only part of it. The more important thing, at least to me, is subjective. You have to ask the patient, how do you feel, right? If you feel like your low testosterone symptoms, kind of, the ones we just discussed, you want to treat the symptoms. You don't want to necessarily treat the number. Like I said, the number just gives us part of it. And historically, we've always checked total testosterone. However, there's a lot more layers to this. There's the free testosterone that you're talking about. As part of the free testosterone, there's the sex hormone binding globulin that goes into that calculation. So there's a number of things you have to check along with it. And that gives you even more information. So, it's treating testosterone. There's a lot of clinics that do it. Men's health clinics, primary care doctors are doing it, nurse practitioners, PAs, even in a place like here in Los Angeles, they're doing it. And they're just, for some patients, it works to just treat the total testosterone. But there's a lot of intricacies to it. It's a lot more complex than people think.
Yeah.
I mean, as you and I know, as both physicians, we've talked about this a number of times, but there's a lot of intricacies to managing testosterone based on those values.
So since we last talked, I've been thinking a lot about the role of testosterone replacement in people who are asymptomatic, right? And I guess, that's a tricky one because they might actually be symptomatic in different ways. And I know that's not something that urologists typically would recommend. Like even if say you have a testosterone that's on the lower side of normal, but I'd love your comments, I guess, on a few things that I've been thinking about and reading about. For one, there seems to be a pretty strong link between low testosterone and metabolic syndrome. And I've talked quite a bit on this show as metabolic syndrome. It's like this silent sort of killer that makes every other major disease that kills us more likely. Diabetes obviously is sort of downstream of metabolic syndrome. When we get to cardiovascular disease, cancer, and so on and so forth. So if you have a guy presenting with metabolic syndrome, he's not necessarily complaining about sexual side effects. Maybe he's not even just that interested in it, right? Maybe he's not interested. There's guys like that, right? Who just don't even think about sex much or that kind of thing. Should you be testing for testosterone in those situations, right? I mean, maybe metabolic syndrome or insulin resistance should be considered another symptom to look out for when you're working up low T.
I agree with you that, there's obviously a correlation between low testosterone and insulin sensitivity, insulin resistance, your lipid profile, your cholesterol levels, all of that. But, to treat, I've never seen this. I've never seen where you have no symptoms of low testosterone, but you're only having, diabetes, high cholesterol, what have you. However, I'll say this, when in this scenario, let's say a patient comes in with this scenario, I think it's important to talk to them about what you just said. Like, look, maybe your blood sugar levels could go down, your A1C could go down, your cholesterol profile can improve. And at the very least, you could talk to them, or at least I do. I talk to them like, look, we even do a short course of testosterone. because testosterone for a short period of time, for a month, 2 months, doesn't cause any, I mean, if you come off of it, doesn't cause any deleterious effects. So you could do it for a short course of time. Even if it doesn't improve your testosterone, your insulin sensitivity or your cholesterol profile, at the very least, what it does, it gives you energy. What does energy mean? You're more likely to exercise. And that even indirectly, maybe you could even say directly, will improve your metabolic profile, right, as you described. So even if it doesn't act biochemically at those receptors, it can at the very least improve their exercise performance, and in doing so, improve their metabolic profile.
Yeah, it's something that I just keep thinking about, honestly, because it to me, I think about like what Peter Attia calls medicine 3.0, and really it's what we're really all talking about is just sort of a personalized, more aggressive type of medicine. And the parallel I think about, Justin, is, well, for me personally, I significantly suppress my my lipids, right? I have got, my LDL is like down in the 20s, and my ApoB is extremely low. It's like for like a 10-year-old boy, basically. And I do this because my idea is that I'm going to make it so that there's a preventable disease out there called cardiovascular disease. Is the number one killer in the world. I don't want to die of it, right? And I can prevent that. So similarly, I kind of think about this paradigm where I'm like, well, should we be thinking about hormonal deficiencies in the same way? If it is the case that there's all sorts of potential downstream sequela of not treating this early, including metabolic syndrome. And as you know, metabolic syndrome is probably like the biggest, most underappreciated cause of all these diseases out there. Why wouldn't you hit it aggressively? And again, I'm not asking you to answer that. I think it's a bigger question, but that's really kind of where I'm going with this.
Yeah, I couldn't agree with you more. I mean, being proactive about checking your hormone levels and being proactive about treating it is paramount.
What are some of the other things you mentioned? Mood disorder, sort of like depression, I'm guessing, more?
Yeah, depression, irritability, along those lines.
Brain fog's a big one, right? A lot of guys talk about brain fog.
Similar to fatigue, right? Right.
Bone density is another one, right? Isn't that also an issue, or not so much?
Yeah, we see bone. So if a young guy, for example, comes in and he's complaining of symptoms of low T, and he's like, you know what, I just broke my femur, or I just broke my, like one of these big bones. He broke. Then we'll get a DEXA scan just to make sure he's not experiencing any early onset osteoporosis, osteopenia.
Let's go over some of the options for testosterone. By the way, I want to point out one thing. I got a question on the show in our Q&A section a few weeks ago, asking about testosterone and testosterone replacement therapy and specifically increasing risks of cancer. Now, I haven't really found anything that suggests that is a real concern. Can you talk a little bit about that?
Yeah, great question. So there was a study that came out, the first study about testosterone replacement therapy and prostate cancer came out in the late 80s, early 90s, sometime during the 90s. Don't quote me on the date. But anyways, It was a study that had some kind of significance in terms of testosterone replacement therapy and prostate cancer. Now, when you look at that study, it was done quite poorly. There was women in the study. It wasn't a properly controlled study, and there's many people have been trying to have them remove that paper, at least take it off, unpublish that paper.
There was women in the study. How could you have women in the study for the prostate?
In the data set, it wasn't purely prostate cancer. They were looking at testosterone replacement therapy and other types of diseases. But anyways, since then, and I probably checked this about 2 years ago, they've probably published, I think they published 19 or 20 papers since that point, and all of them have essentially disproven that original conclusion that testosterone replacement therapy causes prostate cancer. Now, again, there is no, and I could talk about this for a while, but there is no correlation between testosterone levels and PSA, which is what we measure for prostate cancer, above the number of 250. We've done extensive studies on this. So any testosterone level above 250 will not raise your PSA, should not raise your PSA, right?
Right.
Below that, it will raise your PSA. But again, back to your original question, there's no correlation between the two. If anything, these days there's some, there's clinical trials going on at some of these major cancer institutes in America where they're using high doses of testosterone replacement therapy to treat metastatic prostate cancer because it improves your immune system, right? It improves your immune response to fighting these cancerous cells. Like you need testosterone. I mean, it's very important for all of us. How you administer it, again, it's important, but that connection between testosterone and prostate cancer has been disproven.
Yeah, and I want to take that a step further because the point I brought up, and again, just, I'm not a urologist, but just looking through the literature, one of the things, again, that I find compelling about that is what I found compelling was, again, the inverse correlation of, adequate testosterone replacement with metabolic syndrome. And again, metabolic syndrome is a risk factor for increasing the risk of multiple different types of cancer. So if you are actually treating low testosterone, you could take one sort of a leap there indirectly and say that you could, in the process, be decreasing the risk of various cancers by decreasing your risk of diagnosis of metabolic syndrome. So
yeah, exactly.
Yeah,
exactly.
So we've talked a lot about lots of reasons to be on testosterone. I am, I'm sort of convinced of this, to be honest, at this point. I think for health span, lifespan, any number of reasons. What are some of the downsides, though? What are some of the things that people should be thinking about as the risks, any sort of downside related to hormone replacement?
Clotting, any recent cardiac events, cardiovascular events, so stroke, heart attacks, anything recently, any recent stents, cardiac stents. Mm-hmm. If you have a history of any type of blood dyscrasia, so if you have like elevated red blood cell counts, mm-hmm. Testosterone replacement therapy can raise that if you monitor it closely. And then also, if you raise your testosterone levels, you could raise your estrogen levels, causing some side effects there where, gynecomastia. However, I mean, so like the gynecomastia, we could monitor that and regulate that, and make sure that doesn't happen. The other ones, but the cardiovascular events, the clotting, those types of things, those are a little bit harder. I think it requires a thorough discussion with your doctor. There's a lot of risk with that, so it's hard to necessarily mitigate that risk. But these other ones that I described, we're able to, mitigate that risk. That's the best way of saying it.
Right. So specifically, some of the things, again, just as a summary, high hematocrit. So, basically your concentration of your blood cells, and that could potentially lead to an increased risk of clotting. Ways to mitigate that would be, frankly, you could give blood, right? I mean, people do that maybe, quarterly or whatever. Exactly. And sort of bring that hematocrit down. And then the estrogen, the way you would maybe treat that is there are some anti-estrogen pills, like I think Arimidex is one, right? That Exactly. would be an option. So does that in itself cause any side effects, bringing the Arimidex and kind of messing with those estrogen levels?
Yeah, so as much as important as testosterone is for guys, estrogen is very important as well. Mm-hmm. So you never want to bottom someone's estrogen out. The key number is you want at least a 10-to-1 ratio between your testosterone and estrogen. Everything above that is fine. The higher, the better. But you really don't want to bottom out estrogen levels. So typically I like to shoot for, I'd say 30 to 50 for someone's estrogen levels, depending on what their testosterone is, because estrogen is involved in a number of things. Libido is a big one. So we know that guys who have low libido, you have to check their estrogen levels to make sure those aren't bottomed out or too high. And then the other thing is for bone homeostasis. I think, remember in medical school, bone density is reliant in some ways on estrogen levels as well. So you don't want to bottom them out there. And then finally, we're starting to learn about cholesterol levels having a relationship with estrogen as well. So both of these hormones are important, testosterone more than estrogen, but as guys, we all need some estrogen in our body. Right.
Got it. Let's talk a little bit about the different options for testosterone. And we talked about this last time, but effectively, I mean, the traditional way to do this is through injections, right?
Exactly. Yeah.
So injections that you do at home, the intramuscular injections, usually like twice a week?
Yeah, so once or twice a week, depending on the younger guys. I generally recommend twice a week. Yeah.
Is that always intramuscular? I think there is a new product that came out that's subcutaneous.
Yeah. So you don't have to do it. You don't have to do intramuscular. Subcutaneous is, if it's easier for you, do subcutaneous. There's a new, well, it's not so new anymore, but it's called Xiasted. That is subcutaneous. But either way, you know, you can either inject it in your belly fat or your muscle.
Yeah. So, and then pellets. Do you do these pellets, the implants?
Yeah. So Testapel is the big one. We insert anywhere from 10 to 12, sometimes higher, pellets, and they give you a nice steady state of testosterone for 3 months.
Where do you put those, in the arm?
No. So in the upper outer quadrant of the buttocks. So
okay.
Yeah, so there's a big, you know, there's a solid fat pad there, and you're not really putting, you know, you don't sit on that area, you don't put pressure on that area, so it's well hidden, and there's minimal pressure there.
Yeah, and I'm assuming it's a pretty tiny incision and all that kind of stuff.
Oh, yeah, I mean, maybe a couple millimeters.
And then what kind of limitations do you have with that? I mean, you can't sit in a hot tub or anything like that, or no issues.
There's no limitations.
Yeah.
There's no real limitations. The challenging part with that one, though, is you're committed for 3 months to that dose. So some guys, I'll offer it to guys, but it's like after you've tried injections, you've tried orals, whatever it is, you found exactly what works for you, and then we could use that value to create a pellet version of that milligram dosage for 3 months.
Yeah. Okay, so let's talk a little bit about the pellets. Do you, in your opinion, how important is it to just keep the steady state? Because I would think that, I mean, I don't know exactly the details of this, but I would think having a steady state would be a much more desirable thing to do than kind of go up and down, right? I mean,
definite. Well, so I'll say this. It depends what you're looking for. So for convenience purposes, obviously, like the pellets are great. The steady state of the pellets is also great because you're not getting those fluctuations, you're not getting those rises and falls. So what does that do? It decreases your chances of erythrocytosis, so the increase in red blood cell concentration.
Oh, it does.
It does. So the injections are probably the number one reason why you get, or the most common reason why you get increased red blood cell count, because you're getting those spikes, those weekly spikes, and that causes the increase in red blood cell production. So you get less of that with the pellets. But that's the main thing. You get a steadier state, so you get the decreased risk of side effects associated with the testosterone.
Mm-hmm. How about estrogen and stuff? Is that affected as well? Is that, I mean, what makes it so that estrogen is going up if you're just taking testosterone in the first place?
Yeah, so so the enzyme that converts testosterone to estrogen is called aromatase. Mm-hmm. So the medications we give are called aromatase inhibitors. Anyways, aromatase exists in our fat cells, in our adipose tissue. So guys who are heavier, guys who are obese, close to being obese, if they start on testosterone replacement therapy, I'll always start them on an estrogen blocker as well. Mm-hmm. Because they're going to convert more testosterone to estrogen, right? That's just the nature of what they're going to do because they have more fat.
Right.
And there's actually I read an article this morning that there's this argument that we should start these guys on GLP-1s as well. Oh. So to decrease their fat, obviously help them lose weight in addition to boosting their testosterone, because the argument was, hey, listen, these guys are converting so much to estrogen. It's not helping the testosterone levels. But anyways, it was an interesting article about GLP-1s and hypogonadal guys.
That's interesting. So we're, just so people know what GLP-1s, basically we're talking about like the whole Ozempic and,
Mounjaro,
Wegovy, whatever. And so, yeah, that makes sense. So it's almost like, gosh, it's sort of an interesting problem to have men with a lot of belly fat, central adiposity, who have metabolic syndrome, in part because their testosterone's low, and then trying to get them fixed, essentially because now you've got more of it getting converted to estrogen, and you're fighting that battle until you get that fat down to a certain level. Is that kind of the battle that you're fighting there?
Yeah, I mean, and then So that's the battle we're fighting from like a blood value standpoint.
Yeah.
But then the hard work is the lifestyle changes that these guys have to do. Like that's where the real heavy lifting comes in.
Right. That makes sense. I'm going to talk about the less, the ones that are kind of coming out that are interesting. There's a couple other types of testosterone. One is the nasal version, and then there's pills. You want to talk about those options, sort of the positives and negatives?
Yeah. So the nasal one is called Natesto. This has probably been out for a few years.
Yeah.
You have to intranasally instill it. You have to do it 3 times a day. The one benefit to that one is it doesn't cause the fertility side effects associated with testosterone.
Yeah.
So one thing I actually forgot to mention this earlier is when you're taking testosterone replacement therapy, it essentially makes you infertile for as long as you're on the therapy, because it shuts down your testicles' testosterone production as well as sperm production. So that's something to be very mindful of if you're taking testosterone replacement therapy. Natesto doesn't cause that suppression from a sperm standpoint. However, the side effect, the guys don't like it because it causes this postnasal drip. It's 3 times a day. It's inconvenient. It serves a purpose for some guys. To be honest with you, I have a lot of patients, or some patients, who do it before going to the gym. I think you and I have spoken about this, but they'll do it right before they go to the gym, 15, 30 minutes before. It gives them a little bit of a boost. They're able to get a better exercise as a result of it. So that's Natesto. That's the nasal one. The other ones are the oral therapies. Some of these have come and gone. They actually work pretty well, the newer versions of them. They used to be metabolized by the liver. There was some liver side effects, hepatic side effects. They've changed the metabolism of these now. They're absorbed in a different way, so you're not getting the liver side effects. Tolando came and went. It's not doing so well anymore. But the main reason why these things come and go is because of insurance reasons. However, there's one now that has kind of avoided all the insurance hurdles. It's called Kysotrex. And most of the orals, the one benefit, or one of the benefits of the orals, is it increases the free testosterone. So we talked about this earlier. Total testosterone is important, but free testosterone is it's the most important, the bioavailable testosterone. And these oral therapies, Kysotrex being one of them, raises that free testosterone better than any other testosterone replacement therapy.
No kidding. Interesting. Yeah. And then, but it doesn't, does it also increase the total testosterone?
It does.
Okay.
Exactly.
Yeah. And it has like a pretty short half-life, I understand, with the Kysotrex. That's the other thing. So that creates one little wrinkle with both of these, with the Natesto, the nasal one, and this, which is like, how do you, I mean, with the other kinds, you're kind of looking at those numbers to see how they're going up and down, and you're trying to calibrate, what dosing to do. But in these, with the half-life really short, it becomes a lot more challenging. So how do you calibrate your numbers if those testosterone, blood testosterone levels are moving so quickly?
You want to, you have to check it. Your timing for checking it has to be a little bit more precise. So you want to check it the trough, so before your next dose. But yeah, to your point, it is a little bit more difficult. But then that's why the question always becomes, how do you feel? If you're feeling better on it versus when you weren't on it, that's probably the most important test.
Right. And ultimately, like you said, free testosterone is sort of like what you're looking at the most. And so even if your total testosterone really didn't budge, but your free testosterone went higher, you would be fine with that on something like Kysotrex?
It'll go up. The free will, if the total goes up, the free will go up.
Yeah. Got it.
Those will always go up together.
What's on the horizon? Do you know if there's like other stuff that's being tested right now? Different kinds of, I'm just curious that this stuff seems to be changing so quickly, and the demand is so strong.
Yeah. So, we've tried patches. We've tried, for guys who are anorchid, like, the guys who don't have testicles, they've tried to implant animal testicles in their tissue to see if that produces testosterone. There's nothing, stem cells, we could always talk about stem cells, but that's always going to be around. I think one of the newer things when it comes to testosterone replacement is, we're trying to see which one, basically we're trying to find out how we could boost testosterone levels with testosterone replacement therapy while also preserving fertility.
Right.
So that balance, that in between, because right now you have to pick a side. If you're interested in fertility, you only have a couple options for boosting your testosterone.
Right.
If you're not interested in fertility, you have all the options of testosterone replacement therapy. So we're trying to fill in that gap. So right now they're doing a clinical trial for Kaisertrex to see whether or not, because as you alluded to, the half-life is so short, the impact on fertility may be a lot less than the other forms of TRT.
Yeah. I mean, in fact, you were kind of alluding to that offline, that you didn't think Kaisertrex really had that much effect negatively on, on the testes. I'm assuming that's just from your own personal experience in your patients, right?
Yeah, just anecdotally.
Yeah, anecdotal. So interesting. When you think about like all these options based on what's available, what's your like? Do you have a preferred run right now? Is it Kaisertrex? Is it oral testosterone? Is that your preferred method?
I would say so. It depends. Younger guys, I'd either oral, so Kaisertrex, or twice a week injections.
Mm-hmm.
And then older guys, I would say either injection. And when I say older, I'd say probably 60 plus, either injections or testosterone pellets.
Yeah. Yeah.
Yeah.
And that's just because, again, the fertility issue and keeping steady states and that kind of thing. For older guys, the fertility issue might not be as big an issue. And then keeping a steady state testosterone is really sort of the ideal situation.
And it's convenient. I mean,
Right.
the injections, older guys can do an injection once a week. Sometimes they do a larger injection every 2 weeks, or pellets once every 3 months. So just more convenient for the older guys.
Yeah. I mean, it just looks hard. I mean, like for traveling and stuff like that, the injections, I mean, I don't even know if they allow the needles. I mean, do they not allow?
Yeah, you just need a doctor's note, but they do. Yeah,
Yeah, that's
yeah,
interesting.
it is. I agree with you. It's inconvenient.
It seems like a real pain in the butt. No pun intended there, but best time to get the labs typically is always going to be in the morning, right? There's a lot of intraday variability in testosterone. You want to talk about that? Because that's, to me, that was one of the things I found very shocking at how much variability there actually is during the day.
Yeah, I mean, not only just during the day, but even, I mean, you could even span this out over the year, where in the summertime, your testosterone levels are probably higher, wintertime, lower. But peak levels of testosterone, we always say as soon as you wake up. So we typically tell you, check your testosterone levels before 10 a.m. I would even say before 9 a.m.
Yeah.
And then throughout the course of the day, your levels decrease. And that's why, nocturnal erections, or, with the morning wood, when you wake up with it, part of it, the reason is because your testosterone levels are so high in the morning.
Is that the medical term, morning wood, for
morning wood?
That's hilarious. That's the medical terminology there. It's a Latin, Latin-based. Okay, so while I've got you here, I've got some other interesting stuff I'd love to talk about, with regard to erectile dysfunction, stuff that I've been reading. Of course, we know that low T is probably the most common cause, but one of the things that you mentioned on our last podcast was that to a certain degree, there's evidence to suggest that erectile dysfunction is sort of like the canary in the coal mine when it comes to cardiovascular disease. You want to remind us what you meant by that?
Yeah. So the blood vessels that provide blood flow to the penis are quite small, are very, very small. And usually if you're experiencing any blockage, like you were talking about, cardiovascular events, any type of blockage, it's usually, you're going to notice it in these smaller ones because that's going to lead to less blood flow. So anyways, if you are experiencing those types of, erectile dysfunction, that's why it's always important to at least get it worked up, to go on these websites, Hims, Romans, to buy medication. Those are Band-Aids. But if you're in your 50s and 60s, just, get a workup, see where your cholesterol levels are, your blood sugar levels, see if there's something reversible that we can correct. So you're not, this doesn't lead to something else down the road, much, much more severe. Right.
Because it's interesting. There's a school of thought about, and this is talking about a different brain, the actual brain in your head. School of thought with regard to Alzheimer's disease that I've been reading about, that believes that that like beta amyloid plaques and tau proteins, all these things in Alzheimer's may actually not be the cause of Alzheimer's like the way we've been kind of taught, and that it might actually be sort of a downstream reaction to the insult itself, and the thought being that Alzheimer's disease might really be caused primarily, and dementia in general, by a mixture of low blood flow and perhaps some insulin resistance. In fact, people are, that the terminology there, I don't know how long this has been, fairly new to me, is type 3 diabetes mellitus, insulin resistance at the blood-brain barrier. But what I thought was really interesting is that erectile dysfunction drugs like Viagra tend to actually increase blood flow in the penis, obviously, but there's some evidence that the correlation between, there are observational studies, but that people taking erectile dysfunction drugs seem to have less Alzheimer's disease. Can you comment on that?
Yeah, so I know what you're talking about. So like anything else, right, there's probably other variables involved. So, if you're taking erectile dysfunction drugs, you're probably healthier because you're engaging in more intercourse. More intercourse means less stress. It means more intercourse means your hormone levels are probably higher.
Sure.
You're exercising more. So there's
lots of confounding variables there for sure.
Precisely.
Right.
But all in all, here, and we've talked about this last time. Remember we talked about taking Cialis daily.
Mm-hmm.
So there's no harm in that. Can it increase blood flow to the brain? We know it has systemic benefits. Now, can it have increased blood flow to the brain? Even if it does it a little bit, why not, right?
Yeah. Now, as a reminder, what's the mechanism on those drugs? They're phosphodiesterase inhibitors, right? So we're talking about Viagra, Cialis, all these kind of work in a similar fashion. How does that work?
So what they do is the phosphodiesterase inhibitor increases nitric oxide. At a cellular level. Nitric oxide leads to through a cascade. It leads to dilation of the blood vessels. So therefore, more dilation, more blood flow. So more blood flow to the penis, more blood flow systemically. Hopefully, more blood flow to the brain.
Right. That's what another thing I think is just fascinating. It brings up this whole issue again of potential preventative type things too. So is there an element, do you think, in erectile dysfunction of kind of use it or lose it? In other words, if you're not getting a lot of erections, or there's the blood flow, is it a negative feedback loop where you're basically making it less likely over time that you'll be able to maintain erectile function?
Yeah, definitely. So they use it or lose it. I think it was a joke in 40-Year-Old Virgin, but it's true. It's true because what happens is as you age, the strength of your erections go down just naturally, and what happens is you start to get this fibrosis.
Right.
You get this penile fibrosis. So the more so to the point about, again, daily Cialis, and even if you're not getting erections daytime, at nighttime we're all getting these nocturnal erections. And if the strength of the erection is 90, 95, 100% compared to 70% that you would get without the Cialis, that extra blood flow, that extra stretching of the smooth muscle, the more nutrients, oxygenation of that tissue is going to decrease the risk of fibrosis. And the thing is, we're all going to get ED, right? That's just a fact of life. But if you could decrease the curve, or at least delay the onset of it with these medications, why not?
Yeah, and so that brings me to sort of, again, the preventative approach to this, which we talked about. Treating testosterone aggressively. And then the question is, should every man over the age of 40 possibly be on low 5 milligram daily Cialis?
If you could tolerate it, I'll always tell patients about this, right? I'll offer it to them. Even some guys, like I have some friends who are physicians in their 30s who are doing it regularly.
Right.
I'll always offer it, just to discuss it with them. Shared decision making obviously is important. If you could tolerate it, it's generic now, so it's cheap. Side effects, very, very few guys experience any of the side effects. You never develop, from a biochemical standpoint, you never develop any sensitivity to it. So it's not like you're screwing yourself over long term by taking it. So I would say, to answer your question, I would say, it's a discussion everyone, or a lot of people, should have if you want to personalize your medicine, delay the onset of ED, all these. If you want to be proactive, it's a discussion everyone should have. Yeah, for sure.
I would tell you this too. It's what's interesting is beyond the other peripheral benefits. A friend of mine listened to our last show and went on like hymns or whatever and got that. And he's like 58. And this guy has been, he's been very active throughout his life. He's like, prolific. And he's slowing down, and it was depressing him really badly. He started the daily stuff. I mean, he's like, it's changed his life, man. He's back. Huge dramatic change in, his health span, his confidence. It's unbelievable. And it's just basically a little 5 milligrams generic Cialis that he's taking every day. It's such a huge difference.
And the other thing is, it can improve your libido. So, some guys, if you're not good at sex, I won't say not good at sex, if you're not getting good, strong erection, subconsciously, you're not going to want to engage in that act.
Right.
But, like this, him, he probably is getting strong erections. Now his libido's up, and he's back. So he's back. It helps with that as well. Yeah, for sure.
Okay. Last question. I don't know that we talked about this online last time, but I found it fascinating about like a bunch of, guys who are like older, they're kind of past this, and they've past the ability to have any of these drugs really solve their problem. They're going to a pump, which sounds like, when you hear it, it sounds like, oh my God, are you kidding me? But you told me these guys love it. Tell us about how it works and like why. I mean, because obviously they're kind of a bunch of like, wealthy friends or whatever who want to do this or whatever. But why is it so good? And like, how does it work and how does it look?
Yeah. So it's, I wish I had a model here, but it's a penile pump that's all internalized under the skin. Your insurance covers this. Okay. So this is not like every insurance, commercial as well as Medicare, all cover this. So if you're at the end of the road with all your other treatment options, this is a great one. It's the gold standard that we have. But anyways, with there's two inflatable balloons that go into the penis. There's a pump that sits between your two testicles, and then there's a reservoir, which is a fluid that sits in your lower abdomen. All of this, again, is inside the skin. Every time you want to have an erection, you squeeze the pump. The fluid from the reservoir goes into the two balloons in the penis, and it gives you a strong erection. Then there's a release valve that releases the fluid after you're done. So no one really knows. You can't really feel it. Like, I have tons of patients who are quite, prolific and active, and none of their partners have ever called them out on it.
Really?
They don't know about it.
Or they at least wouldn't say it. Right. Yeah.
But it's so deep under the skin, you would never even know. It's a great option for, just pump it up. It doesn't impact your sensitivity.
So these guys feel everything normal. Like,
if not, better, to be honest with you, because those nerves are so stretched out. They're super hyper sensitive, so everything feels great.
Really? So they're like when they're 17 years old or something like that, pretty much.
Yeah. A lot of them are. I think I told you this. A lot of them are like, oh man, I wish I did this 10 years ago, 20 years ago, whatever.
Really?
Like, I wish I did this a long time ago. Yeah.
No kidding. And then do they have normal orgasm, all that stuff too? And then can they just keep going? Can they just keep pumping up again in like 10 minutes later? No kidding.
Well, the thing is, their erection is strong, is hard for as long as they want. They have to push the release valve. If they don't want to push it, they don't push it.
Right.
Yeah, so and then the company, so there's two companies that do this. So one of the companies, Boston Scientific, actually, they're creating a Bluetooth version of the pump. So currently it's a mechanical pump. Probably in the next 5-6 years, they're going to come out with a Bluetooth version where you don't even have to pump anymore. You just control it with your phone.
With your phone? You're like, hold on, I get a text. Right, something like that.
Don't lose your phone.
Don't you realize? But then how does that? I'm curious about that in terms of like orgasm though. Like do they control when they orgasm then?
No, not the orgasm.
Okay,
just the strength of the erection.
Right, but the orgasm, they just happen, and they could just keep going. And is there any difference in how frequent they can orgasm based on this thing or not?
No, they're orgasming more than they were before the surgery, but it's not like they were. Not like when you're 18 years old.
Yeah. Fascinating stuff, man. You live in a very interesting world. I think it's kind of fun to talk about, but super helpful, man. Again, you've got a great practice there in Beverly Hills, Tower Urology. It's Justin Houman, assistant professor at Cedars-Sinai. Thanks for being on, and I'm sure, hopefully we'll have you back again. It's always fun to talk about these things. Let us know if there's anything else miraculous coming on the horizon.
Will do. Thanks for having me. Always great.
We'll be right back.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.